Sympathetic ophthalmitis. It is a bilateral granulomatous pain uveitis occurring after penetrating trauma. So penetrating trauma is important, where uveal prolapse may have been a feature after trauma. Less frequently, the condition occurs following intraocular surgery, usually multiple vitreoretinal procedures. The condition has been associated with specific HLA haplotypes, which would suggest that in some patients there is genetic predispositions. Presentation in trauma-induced cases is between 2 weeks and 3 months after initial injury. 2 weeks and 3 months. In 65% of cases, the incidence is probably 0.2 to 0.5% after injury and 0.01% after intraocular surgery. 0.01% after intraocular surgery. 0.2 to 0.5% after injury. Histopathology shows a diffuse lymphocytic infiltration of the choroid. Scattered aggregates of the epithelioid cells are seen, many of which contain fine granules of melanin. Dehlen-Fuch nodules, which also occur in Vogt-Koyanagi-Harada syndrome, are granulomas located between Bruch membrane and the RPE. Clinical features, the symptoms, there is a history of causative trauma. The exciting eye is frequently red and irritable. The sympathizing eye develops irritation. Sympathized eye develop irritation, blurred vision, photophobia and loss of accommodation. Blurred vision, photophobia, loss of accommodation. Exciting eye is red. Anterior uveitis develops in both eyes, which may be mild or severe and is usually granulomatous. So here you can see in the picture granulomatous uveitis with sub-RPE infiltrates. The uveitis develops in both eyes. It may be mild or severe, usually granulomatous. The severity of uveitis and the severity of inflammation may be markedly asymmetrical. Fundus, as you can see, multifocal choroidal infiltrates develop in the mid-periphery with sub-RPE infiltrates corresponding to Dehlen-Fuch nodules. Exudative retinal detachment, vasculitis, optic disc swelling may occur, may all manifest. As inflammation settles, residual chorioretinal scarring may confer a sunset glow appearance similar to VKH. OCT is useful for quantifying and monitoring change. B-scan may demonstrate choroidal thickening. FA shows multiple foci of leakage at the level of RPE with subretinal pooling in the presence of exudative retinal detachment. ICGA shows hypofluorescent spots in the active disease which resolve with treatment. Ultrasound may show choroidal thickening, exudative retinal detachment. Treatment: enucleation of severely injured eye within 10 to 14 days of the injury has historically been considered effective in preventing or reducing the severity of sympathetic ophthalmitis and should be considered for an injured eye with a hopeless visual prognosis. Evisceration is an acceptable option provided all uveal tissue is removed. Steroids, high dose. Steroids are the basis of initial treatment. High dose oral prednisolone is given for several months and gradually tapered according to response. Initiation with intravenous methylprednisolone may be used in some cases. Supplementary topical steroid cyclophages may be given to target anterior uveitis and periintraocular steroids Including slow release intravitreal implants may facilitate or reduce systemic treatment. Immunomodulatory treatment should be considered early in the course of the disease.